So right before we started the break, this is the last slide that I ended on, talking about the way fatty acids work. And this is, certainly not all-inclusive, but I wanted to make sure that we all understand that fatty acids not only work by, functioning as cyclooxygenase and lipoxygenase modifiers, but also by actually modifying genetic expression. And one of the ways they modify genetic expression is through activation of PPAR alpha and PPAR gamma. So PPARs, here's another good example of, let's see, how do I say this? Gosh, this goes back a long time. So there was a book written by, I think his name is Walter Lippmann. I think his name of his book was Public Opinion. But anyway, one of the things he talks about in that book is how to create perceptions among the public. And that's where, Noam Chomsky's work was in part derived from, in terms of like social control through media and things like that. Anyway, the relevance of that to this conversation on PPARs is, who in here knows what PPARs do? If you just look at the name PPARs, does it make any sense at all? Right? What does PPAR stand for? Anybody know? It stands for peroxisome proliferator activated receptor. Right? That's what PPARs are. Great. Does that make any sense to anybody in here? It doesn't, does it? So what if we call them, instead of calling them PPARs, which you cannot take action on, what if we call them fatty acid receptors? Then it makes sense. So we're talking about the same pathway, the same implications, and if we collectively refer to them as PPARs, which is what the TZD drugs are. Remember the drugs I was talking about earlier that cause heart failure in diabetic patients? Those are PPAR agonists. It's important that we continue calling them PPAR agonists because then no one will know how to work around that system. But if we call them fatty acid receptors, then shazam. Notice how it shifts the paradigm. If you call them PPARs and say, look, here's a drug that activates PPARs, who's in control? Drug companies. If you call them fatty acid receptors, who's in control by definition? Whoever's controlling the diet, right? So let's call them fatty acid receptors. And here's an easy way to remember it. So whether you're talking about PPAR gamma or PPAR alpha, they both have an anti-inflammatory effect when they are activated. So your goal, in part, as a clinician, is to activate these PPARs, PPAR alpha, PPAR gamma. Again, if we're not going to call them PPARs, we would call them fatty acid receptors. So we could call them fatty acid receptor alpha, and we could call it fatty acid receptor gamma, right? Instead of PPAR alpha, PPAR gamma, let's use a terminology that makes sense, because theoretically, we're using language to convey ideas, and we have to understand what those ideas are. So having said all that, the take-home message and the way to apply this clinically is when you think of PPAR gamma, you want to think anti-inflammatory effects, and you want to think of PPAR gamma as being activated by gamma-linolenic acid. How perfect that it would be called gamma-linolenic acid, and it activates a fatty acid receptor called PPAR gamma. Easy to remember, right? PPAR alpha is preferentially activated by eicosapentaenoic acid, or EPA. So when you think of EPA, you could think of fatty acid receptor alpha. So those are ways, in part, that fatty acids work. Okay, so we just finished, believe it or not, it took us 3 hours to get through just basic info and diet. This is like a world record for going slow. But well, my goal today was simply to get through the protocol and some applications. So whether we do slow, fast, and fast, or fast, and fast, it's all going to be the same. The number of slides we cover will be the same, whether we divide it up now or later. So now we're going to talk about infections and dysbiosis, one of my favorite topics. So when I say chronic infections, I mean that's one of the definitions, or that's part of the definition of dysbiosis. But whenever you deal with a patient who's got any type of inflammatory disorder, one of the questions I want you to ask all of these questions, but certainly one of the questions is, where's the infection? And where's the microbial stimulation coming from? Important concepts. Subclinical infections are common in patients with chronic inflammatory diseases, especially autoimmunity. Any inflammatory disease that I can think of, and probably you as well can think of, has some type of microbial infection associated with it. Whether you're talking about Alzheimer's, In that case, it's what? Herpes simplex type 1, chronic infection in the brains of people who have Alzheimer's. We can talk about that later. I've got the articles. We can look at them. If you look at rheumatoid arthritis, that's the perfect example of chronic inflammation caused by chronic infection. If you look in their throat, they've got beta hemolytic strep. If you look at their urinary tract, they've got Proteus mirabilis and Proteus vulgaris. If you look at their gastrointestinal tract, they either have nonspecific bacterial overgrowth or they have a bacteria called Eubacterium aerofaciens, which, when taken from the gastrointestinal tract of rheumatoid arthritis patients and implanted into animals, it actually causes rheumatoid arthritis, just like their beta hemolytic strep in their throat. If you look at Organers granulomatosis, it's usually nasal carriage of Staphylococcus aureus. If you look at psoriasis, it's any microbe you can name, usually a couple times over. What else? Those are the classic examples. If you look at antiphospholipid antibody syndrome, also known as Hughes syndrome, I believe, the microbial infection there is chronic cynorespiratory infection with Haemophilus influenza B. So there's a very well-defined microbial infection associated with just about any inflammatory condition you can think of. So we'll talk about subtypes of that. So one of the things that I had started to develop was a concept which ultimately was better articulated by Bill Meggs. That's M-E-G-G-S. If you look up his articles, he's certainly published some brilliant work. And one of the things I heard him discuss at a presentation a couple years ago, I didn't do it on purpose if I did. Yeah, no, I just think we lost sound. That one's running. Oh, we have some spare batteries. This one says it's on, but the battery light's red. So we'll change that out. All right, now we're green again. Okay. So one of the things that Bill Meggs said a couple years ago, this was in 2008, he said what you look at when you're looking at autoimmune diseases and chronic inflammatory disorders, he says what you're looking at are what he calls patterns of inflammation. And what we as healthcare providers, and certainly as in the medical doctor world, what we've all kind of been indoctrinated into is this idea that we have to give a different label to different diseases, whereas we should be looking at all of these as the same disease with different manifestations, right? Patterns of inflammation. So, for example, and that's more and more true all the time, and I can give you some examples of that. One example of which is the fact that over the last couple of years there's been something, I think the phrase for it is overlap syndromes. And what overlap syndromes refers to is overlapping of different autoimmune diseases. You know, for example, when you look at patients with rheumatoid arthritis, they usually have Sjogren's, or they often have Sjogren's. And a lot of times what you'll see in patients with autoimmune disease A is that they also have autoimmune disease B. Like this patient I'm working with, we're going to go through his case in just a moment. He's got psoriasis, which is an autoimmune disease. He's got rheumatoid arthritis, which is an autoimmune disease. And he's also got Hashimoto's thyroiditis, which is another autoimmune disease. So he's a good example of what we could refer to as overlap syndrome. He's got an overlap of several different autoimmune diseases. So what are we going to do? Are we going to treat each one of those diseases separately, or are we going to let the light go on and say, wow, this guy's got immune dysregulation, we need to treat his immune system, rather than chasing down each one of these diseases, right? Anybody have a preference for what we do? Anybody in favor of the label? Anybody want to chase the label? Right, that's what we do in medicine. We chase labels. We label people, and then we treat them like diabetics, we treat them like hypertensives, we treat them like they're depressed. Nobody, except us collectively, puts it all together and says, hey, let's look at the pattern here, right? So you'll see that play out when we talk about dysbiosis. The microbes alone are not the problem. What I call total inflammatory load, or TIL, must also be addressed, as well as what I refer to as immunorestoration to prevent recurrence of colonization. So patients with chronic infections, by definition, have some type of immune defect, otherwise they wouldn't have the colonization to begin with, right? So is it appropriate to just treat those patients with antibiotics and then let them go back to the lifestyle and physiology that led to the infection to begin with? The answer would be no. Which is why when you look at the medical studies that have examined this process, usually what they show is short-term benefit, which proves that antimicrobial therapy works for autoimmune diseases, but then they qualify it, almost always they'll qualify it, but following treatment the patients relapse and therefore we can't recommend this as therapy, right? Well, why do the patients relapse after the antimicrobial therapy? Because they're still nutritionally deficient, no one changed their diet and lifestyle, so of course the infection came back. To me, that's just common sense. Like, I'm waiting for that result. And that's why I don't see that result in my practice, because I might hit them with antibiotics for a month or two, but then by that time I've restored the function of their immune system and they're able to fight off the recurrence of the infection. So how do we assess this clinically? You can do culture and sensitivity. That's what I do. I use a lab called Doctor's Data for my stool testing. We do 3 sample stool tests, and we might add on a few other samples. A lot of labs these days use DNA-based assessments. A lot of clinicians find them to provide not very accurate information or not very clinically useful information. And just as an aside, I'll just mention that if you look at the data on DNA-based testing, some of it's very accurate and some of that accurate technology is clinically available. But some of the DNA-based testing is tightly protected by patent. And some of the labs that are doing DNA-based testing, they're calling it DNA testing, but they're having to circumvent certain patented and copyrighted procedures. And in other words, their technology is not quite as good. They're describing it as the same, and they're saying, look, here's research that supports DNA-based testing, but they're using a different methodology. Does that make some sense? So culture and sensitivity at any point in any time is culture and sensitivity. It's never going to be perfect because not everything can be cultured. But DNA-based testing is not as good as we would like for it to be. Now, it's great for gonorrhea and chlamydia, things like that. It's pretty standard. But when we talk about DNA testing for stool, how many different species of bacteria live in your guts? Hundreds and thousands. So unless you're getting a report back that has hundreds and thousands of data points, you're not getting the whole picture. And who has time to go through 1,000 data points anyway? But that's what I talk about. When I talk about patterns of inflammation, part of the reason different patients have different patterns is because they have different microbes creating those different patterns of immune response. So we have to take all that into consideration. Response to treatment is most compelling and meaningful. So, I'm all in favor of lab tests. I do them all the time, whatever. But I'm also not addicted to lab tests, and I'm certainly not going to, if I have to choose between treating a patient and testing a patient, I'm going to treat them, right? People don't come to me for lab tests. Typically, they come to me for results. And I run a cash-only practice. I don't take insurance. People are paying out of pocket. So we've got, unless they're, trying to spend their trust fund, then we have to work within a limited amount of money. If I have to choose between a $400 lab test or $400 worth of treatment, of course I'm going for the treatment, right? Or more visits with me. Therapeutic implementation, antimicrobials, that could be drugs or herbs, immunorestoration, and enhancing inflammatory or immune tolerance. Those are the 3 components to dysbiosis treatment. So remember earlier we talked about the SOAP acronym that you've already learned, subjective, objective, assessment, and plan, and then we said we're going to add on to that, at least thinking about these other 7 components. FIND-SEX, right? So find sex after you've done your SOAP, which works out pretty well. So food, infection, nutritional immunomodulation, which is the immune tolerance component of this, addressing dysfunctional mitochondria, stress and lifestyle, hormonal and endocrine imbalances, and then xenobiotics. So we're working on the I part of the FIND-SEX protocol. So often what we find, and so here's my definition of dysbiosis. Often what we find when we're working with autoimmune inflammatory patients is that they are having a pathogenic inflammatory response to a non-pathogenic microbe. And the best evidence of this is Wegener's granulomatosis as an example. These patients have been shown to have nasal carriage of a bacteria called Staphylococcus aureus. So how does nasal carriage of a bacteria cause a lethal vasculitic condition? Most of these patients, if you look at the natural history of Wegener's granulomatosis, most of these patients are dead 2 to 5 years after their diagnosis if they're not treated. So how does a bacteria in their sinuses that's not causing an active sinus infection, how does that bacteria cause them to have a lethal vasculitis? A better name for Wegener's granulomatosis would be Wegener's vasculitis because it's a vasculitic disease. So how does a bacteria cause vasculitis in that case? Well, Staphylococcus aureus produces an enzyme called acid phosphatase. And ironically, paradoxically, or interestingly, or just fatally, no pun intended, fate as in the Greek fate, the enzyme produced by Staphylococcus aureus has an ionic charge or an electrostatic charge, so it binds onto endothelial cells. So just like we talked about earlier with glycoproteins and the Maillard reaction, non-enzymatic glycosylation, it's another what we could call or generally refer to as a neoantigen formation or haptenization. So haptenization just simply means binding of two foreign things together. So to some extent, when we talked earlier, for example, about the pasteurization of milk, you take a milk protein, you take a sugar, you bind those things together, and now this may or may not have been antigenic, and this certainly wasn't antigenic, but you combine them together, and now the immune system has to respond to something it's maybe never seen before, which is a glycoprotein. Where do we see glycoproteins? Bacteria and viruses, mostly. So anytime we bind two things together that previously weren't together, that's immunogenic. Immunogenic just means immune response generating. So in the case going back to Wegener's granulomatosis, we're binding two things together that have never been together. We're binding an endothelial cell, we're binding an endothelial cell with this antigenic enzyme from a bacteria, which haptenizes onto it through an electrostatic charge. So here's your endothelial cell, and here's acid phosphatase from Staphylococcus aureus. They bind together. Now the immune system attacks this complex. And this is happening in real time within the vascular wall. So what do we call inflammation within the vascular wall? We call it vasculitis. It's, in this case, a pretty lethal condition. Another condition related to this, because it's a vasculitic condition, is antiphospholipid antibody syndrome, also I believe called Hughes syndrome, as I mentioned before. That is associated with Haemophilus influenza B, which is another gram-negative bacteria in the throat. So we see some parallel there. Rheumatoid arthritis, as I mentioned before, the three most common examples of chronic infection in those patients. Actually, there's a fourth example I'll mention. Strep, beta hemolytic strep in their throat. Let's see, what was it, Aeromonas hydrophila? No, that's not right. Eubacterium aerofaciens, Eubacterium aerofaciens in their gut, and then some type of Proteus species in their genitourinary tract. If you combine those three things together, it's a recipe or a setup for the pattern of inflammation that we call rheumatoid arthritis. What else? Ankylosing spondylitis, classic example there is somebody who's HLA-B27 positive, and they have a chronic urinary tract infection with E. coli and a GI infection with Klebsiella pneumoniae. Perfect setup, right? And I actually happened to see that last year. She was like the perfect prototype. Her dad had ankylosing spondylitis. She had ankylosing spondylitis. They're both HLA-B27 positive. I did a stool test on her. She came back positive for Klebsiella pneumoniae. We did a urinary tract culture on her as well, and she came back positive for a very low grade but very evident E. coli infection. So what's the relevance there? How does all that make sense? It's because if you look at the HLA-B27 molecule, which is on every tissue she's got in her body, it has a certain amino acid sequence. And if you look at the amino acid sequence of HLA-B27 and you compare it to the amino acid sequence of E. coli and Klebsiella, it's virtually identical. So when these patients have chronic bacterial infections, their immune system tries to clear the infection by producing, among the different responses, it produces more antibodies or immune globulins against those bacteria. Some of those immune globulins, because of what we call molecular mimicry, cross-react with body tissues and create an inflammatory response in the body tissues, even though the body tissue itself was innocent, so to speak, right? Does that make sense? So if you look at HLA-B27 amino acid sequence, it looks just like Klebsiella pneumoniae and E. coli. So in patients who have these chronic infections, their immune system produces antibodies. Those antibodies cross-react with their own body tissues to create inflammation, and the pattern is ankylosing spondylitis. Dermatomyositis, highly correlated with, again, group A strep infections. Sjogren's syndrome, probably most tightly correlated with Helicobacter pylori, a gram-negative bacteria found in the gut.